Good morning, good afternoon. Thanks for joining us for our webinar today on understanding Medicaid community engagement requirements and new Section 1115 guidance. We have a very full and informative agenda for you today. I will confirm 100% that you will be sent the slides and the recording after the interview, after the discussion. We will have opportunity for question and answer at the end. We anticipate a lot of questions, so if we don't have time to get through all the questions, we will send a follow-up document with answers to those. So please post in the Q&A section any and all questions that you have, and we'll get to as many as we can. And we'll have two sections today, so if we could go ahead to introduce our series. So this is the second in a 3-webinar series on Medicaid coverage disruption. So the first conversation was around state-directed payments, which was on June 10th. Today's conversation, as we discussed, and then coming up in August, we'll be talking about program integrity. So all really big, important topics, and Rob will cover all of those in a moment. You can certainly register for the next webinar, and our recordings are always on our Insights page on our website. So I would like to take a moment to introduce our team today. We'll go in alphabetical order, although that won't be in presentation order, but according to the slide. So Elric Berkman is a consulting actuary at Wakely, which is an HMA company. And Wakely provides healthcare analytics, financial modeling, and Medicaid strategy. Elric helps clients optimize resources and navigate complex payment and policy challenges. Rob Buchanan is a senior principal at HMA, and he helps public agencies, health plans, and providers improve healthcare delivery and outcomes through Medicaid policy, payment reform, and system transformation. Rob was also on the last webinar with us. Rebecca Kellenberg is a principal at HMA and a former director of Medicaid eligibility and advises public and private organizations on delivery system transformation, policy implementation, and strategic planning, with particular expertise in maternal and child health and rural and tribal communities. Laura Saunders is an associate principal at HMA who helps state agencies manage care plans, providers, and other healthcare stakeholders navigate Medicaid and marketplace policy changes through policy and impact analysis, tracking trends, program evaluation, and stakeholder training. Patrick Teig is a senior vice president at HMA and a former state Medicaid director and health insurance commissioner who helps states and health organizations advance Medicaid policy, delivery system transformation, and value-based payment reform. And Chris Underwood is a senior consultant at Health Tech Solutions, which is a new HMA company. We're happy to have them with us, and a former Colorado Medicaid executive who helps organizations strengthen Medicaid operations, modernize health systems, and improve access to care through policy, technology, and strategic transformation. So that is our team. Their complete bios can be found on our website, but let's jump right in to the first section. And Rob is going to give us a little framing for today's conversation against this changing healthcare landscape. So thank you, Rob.
Great. Thank you, Jen. Great. So, as everyone on this call knows, Medicaid is entering a period of significant change. Over the past year, we've seen a series of federal legislative and regulatory actions that are reshaping multiple aspects of the program, from eligibility and coverage to financing, oversight, and waiver policy. Rather than responding to a single policy change, I think it's fair to say that states are managing several major initiatives simultaneously. So we've got new eligibility requirements, increased program integrity expectations, evolving payment policies, and changes to Section 1115 demonstration guidance, all of which require strategic, operational, and technology investments. The common theme across these changes is that they don't happen independently. There's really a layering effect that's happening. Decisions in one area have downstream implications for others. As a result, Medicaid agencies and their partners are having to think more holistically about implementation than ever before. Next slide. So let's start with where we're going to spend our time today. We're going to begin by discussing the new community engagement requirements established under federal law, who will be affected, what the requirements entail, And importantly, kind of what are the key policy, operational, and technology decisions that states and their partners are thinking through as they prepare for implementation. Then we're going to shift to some new CMS guidance on Section 1115 waivers and budget neutrality. While this guidance addresses a different aspect of Medicaid, it reflects many of the same themes that we're seeing across the program. So increased federal oversight, greater analytical expectations, and the need for kind of earlier and more deliberate planning. So throughout this webinar, we're going to focus not only on kind of the federal requirements themselves, but also what they mean in practice for states, health plans, providers, and other Medicaid stakeholders. So with that, I'll pass it off to the community engagement section.
Thanks, Rob. So the federal law establishes new Medicaid community engagement requirements that will reshape eligibility for many ACA expansion adults. And these new eligibility conditions take effect January 1st, 2027. And many of you on this are probably already very familiar with the elements, but to level set everyone's understanding, we'll just go over the high level components of the community engagement policy. So while often referred to as a work requirement, the statute is broader than employment alone. Individuals can satisfy the requirement through work, education, community service, approved work programs, or certain income thresholds. The requirement primarily applies to ACA expansion adults ages 19 to 64 who are not pregnant and not enrolled in Medicare. Importantly, Congress also established numerous exclusions and exceptions. So implementation is not simply about tracking work hours. States must build processes to correctly identify who is exempt and who is subject to the requirement. And for states, the challenge is not just about policy compliance, it's about building the operational infrastructure to administer the requirement accurately and consistently. Next slide. So this slide breaks the policy into three major components: how people can comply, who the requirements apply to, and what protections may prevent inappropriate coverage loss. Individuals have multiple ways to demonstrate compliance rather than a single work-only path. The 80-hour standard can be met through employment, volunteer service, workforce programs, education, or a combination of activities. There's also an income-based alternative for an individual earning at least the equivalent of 80 hours at the federal minimum wage. CMS intentionally aligned many provisions with SNAP and TANF to reduce duplication and facilitate data sharing. The law also includes protections for certain specified excluded individuals, including exclusions for caregivers, former foster youth, American Indians and Alaska Natives, pregnant individuals, people who are medically frail, and others. So states will need strong eligibility processes because determining whether someone is excluded may be as important as determining whether they complied. Next slide. So the enrollment impacts could be substantial. Even modest administrative requirements can affect participation levels. Historical experience from Arkansas, Georgia, and other work requirement demonstrations show that many coverage losses were driven by reporting and documentation challenges rather than lack of work activity. The Urban Institute estimated that Medicaid expansion enrollment could decline by 27% to 55% among adults subject to work requirements, depending on how implementation and mitigation strategies are implemented. States that invest heavily in beneficiary education, data matching, and automated verification may see less disruption. States that rely heavily on manual reporting may experience greater churn and more coverage gaps. Health plans and providers should be preparing now for the possibility of increased uninsured rates and disruptions in continuity of care. And this is why operational decisions matter just as much as policy decisions, as we'll walk through. Next slide. So this slide captures the central implementation framework. Federal law creates the implementation framework, but states still have significant implementation choices. CMS establishes who is subject to the requirement, qualifying activities, major exclusions, notices, and appeal rights. But beyond those federal guardrails, states have several policy and operational decisions that will ultimately shape the beneficiary experience. For example, states can decide how they verify compliance and how much automation they build into the process. These choices have downstream impacts on staffing, call center volume, contractor support, and systems development. And this is why community engagement implementation is as much an operational transformation effort as a policy initiative. The major question we would say is that for states is how to balance program integrity with administrative burden. Next slide. So we're now going to focus in on some of the key policy and operational decisions and how they impact states, health plans, and providers. One of the most important policy choices involves the look-back period and verification frequency. The interim final rule allows states to require 1, 2, or 3 months of demonstrated compliance before eligibility is approved or renewed. A shorter look-back period generally means less documentation, simpler processing, and fewer barriers for beneficiaries. A longer look-back period may provide more rigorous compliance standards, but it can increase workload for beneficiaries and eligibility staff. Federal law requires a review at least every 6 months, but states may choose to verify compliance more frequently. Also, more frequent verification can identify issues sooner, but it also increases notice volume, staffing needs, systems activity, and risk of enrollment churn. This is one of the clearest examples of where state policy and operational decisions may directly influence coverage retention outcomes. Next slide. So another key decision point is whether states will adopt short-term hardship exemptions. The hardship exemption is optional for states, but if a state adopts it, all federally defined hardship categories must be available. CMS views these exceptions as temporary protections during periods when meeting community engagement expectations may not be realistic. Examples include hospitalization, residence in a disaster area, high local unemployment, or the need to travel away from home for specialized medical treatment. States will need to establish processes for reviewing and approving hardship requests and verifying supporting documentation. Providers may plan on an important role because many hardship determinations will require clinical documentation. And health plans will likely become important navigation partners, helping members understand when hardship protections may apply. Despite being temporary, these exceptions can significantly reduce unnecessary coverage losses during periods of instability. And I'm going to hand it over to Chris Underwood for the next slide.
Following the IFR, states need to create a plan and a hierarchy of what documentation will be acceptable for verification of exemptions and community engagement activities. The verification framework in the IFR is built upon the core principle that states use trusted data first, minimize member burden, and ensure that individuals who are eligible for Medicaid maintain access to coverage while preserving program integrity. Therefore, states must use electronic and administrative data first. The goal is to avoid gathering information from applicants and members whenever possible. Examples of these new sources of information that states are working on are integrating their SNAP and TANF records with their Medicaid eligibility, interfaces to payroll data, and interfacing with the Federal Data Services Hub for new information on the National Student Clearinghouse data and Veteran Affairs information. And then they will be integrating with other state and local databases that have not been traditionally used to leverage for Medicaid in the past. In addition, there'll be new forms that states must create that can be used by applicants and members to fulfill verification requirements. This is creating a situation where states are now trying to implement system changes to comply with the community engagement requirements and creating new electronic data sources and interfaces before January 2027. Further, as these system changes are occurring, they are identifying ways to store these verifications, including retaining all electronic interface files so they are readily available for auditors. So eligibility workers need to be trained on these new electronic data sources, the standard forms that can be used, and what other documentation like school enrollment documentations or class schedules that will be allowed by states to verify exemptions and compliance with community engagement activities. Medicaid health plans can help by educating members and their provider networks on the state's verification standards. This may require them to increase their outreach and call center capacity to help members maintain their enrollment. The broader outreach to community partners, health plans, and providers, the better Medicaid population will be supported. Providing these new verifications will be a significant hurdle to becoming Medicaid eligible and retaining Medicaid coverage. Providing verification and even responding to verification requests has always been a significant barrier for the Medicaid population. The process is only becoming more difficult. Therefore, the operations and training around verification policies should be under development right now and not a month before go live. Next slide, please. In 2027, self-attestation may still play a significant role when electronic data sources cannot verify community engagement and exemptions. States may accept other information and are not yet required to demand documentation in all cases. Through December 2027, states may accept information other than formal documentation when verifying community engagement and exemptions. States have flexibility to accept member statements and other form of information while systems mature. The goal is to avoid unnecessary administrative burden while states build their verification systems and operations that will support the more formal documentation requirements beginning in 2028. However, not all states will allow for this flexibility in 2027. Some state lawmakers and policy officials have and will push against self-attestation. And the state may allow self-attestation for some exemptions and community engagement activities, but not for all. The more stringent requirement to obtain documentation when reasonably available and to sunset the broad use of self-attestation does not fully take effect until January 2028. As we discussed on the previous slide, this creates significant training and communication burdens on states to clearly communicate their self-attestation policies to members, health plans, and providers. Health plans need to help communicate can help communicate the available options to members, while providers need to understand how their patients need to document the possible exemptions. Next slide, please. One area where documentation and verification will be critical is when determining if someone is medically frail. But before we talk about operations, the policy around medically frail exemptions must be established. There are 5 categories under medically frail. Those include individuals who are blind and disabled, individuals with a substance use disorder, excluding those individuals who are in stable recovery, individuals with a disabling mental disorder, individuals with a physical, intellectual, and development disability that significantly impairs their ability to perform one or more activities of daily living. And then the very broad category of individuals with a serious and complex medical condition. The most significant change in the IFR is not the 5 categories themselves. They are largely mirroring the existing Medicaid frailty concepts that were established in the ACA. The major change is that CMS is now requiring states to determine whether a person's condition significantly impairs their ability to comply with community engagement requirements, creating a new functional capacity test that claims data alone cannot generally support. This is a central policy and operation challenge for providers, health plans, and state Medicaid agencies. Prior to the IFR, states were preparing to just use diagnosis codes from claims and encounters in their data warehouse and then medical records from their health information exchanges. That requirement has now changed to include this functional capacity test. How states will define that is still in question, and there has been little, if any, guidance from CMS on this topic. States will need to develop audible and justifiable conditions using diagnosis, disorders, and health conditions. States must regularly update these lists, maintain documentation, and make methodologies available to CMS upon request. States must also establish verification processes and use data, documentation, or attestations. Now, claims and encounter data, along with medical screening and health records, can still be used to identify potential applicants and members who may still qualify for this exemption. Health plans can use their data to outreach to members. They can perform targeted outreach to help members prepare documentation and and to generally understand how they can comply with the medically frail exemptions. Providers need to understand the policy and how it is different from SSA's disability criteria or the criteria that states use to determine long-term care. Next slide, please. Even before the policy around medically frail is finalized, states should be thinking through the operations and start planning now. What systems will they use to create and analyze lists using diagnosis and health conditions? Vendors, including health tech solutions, are creating platforms that can be leveraged to help with this. There are groupers such as the Johns Hopkins grouper could be a strong operational tool for identifying people who qualify for the medically frail exemption, even though CMS has not formally endorsed any grouper methodology at this time. The Johns Hopkins grouper is not itself a medically frail determination tool, but it can serve as a highly effective clinical risk stratification engine for implementation. The states could use grouper outputs as part of their ex parte verification process to identify members who are serious or complex that have medical conditions that place them at high risk for harm or Medicaid coverage disruption. In addition, some of these tools have medically frail definitions that can be applied, and if CMS approves, allows a certain number to be determined medically frail without additional screening. Vendors are looking to create these tools so they can be approved and certified by CMS, and then the vendors will have the responsibility of updating the list of qualifying diagnosis and health conditions on a regular basis. This can be leveraged to remove the burden of states having to perform this work. Alongside the data approach, the new functional capacity test will require the states to perform this assessment or contract out the service. States commonly use vendors to help with disability determinations or to perform functional assessments for long-term care eligibility. This new functional capacity test can be contracted out to similar vendors. However, that means states need to start their procurement and contracting process now to make sure they are ready for 2028, or even starting in 6 months if they choose not to accept self-attestation in 2027. In addition, this process can't take a significant time to complete, like often disability determinations do. When someone applies for disability, they are enrolled in MAGI Medicaid while the determination being processed, assuming they have the income coverage for MAGI Medicaid. This means they have access to medical care. However, with community engagement requirements, individuals aren't enrolled in Medicaid until their exemptions or compliance is verified. So processing the new functional capacity test in 30 days or quicker may be necessary to avoid individuals foregoing necessary care. It is also something to take into consideration when states are considering or not allowing self-attestation for medically frail through 2027. This will give states the opportunity to develop these systems and processes until they are ready for 2028, when they do need to perform the necessary verifications. Further, the state's HIEs, or health information exchanges, could be leveraged to provide medical records so they are provided timely. This reduces the burden to retrieve medical records from providers or directly from members. Building this infrastructure with your HIEs and HIT system to incorporate medical records along with claims data and systems that has your group or definition of medically frail can be funded at the 90/10 enhanced federal match rate. But that means you need to start your APD process now. Health plans can be instrumental in this process by coordinating documentation exchange amongst providers, members, and Medicaid agencies. Providers may be asked to provide support documentation or even complete forms to verify that someone is medically frail. Having providers complete this timely is critical to the application and renewal process. Now, that is a lot on medically frail. I want everyone to keep in mind that there is an IT and data analysis component to determining medically frail that is still very important, even if the IFR created a new functional capacity test that is now a priority to define and operationalize for states. Please outreach us if you'd like to have a longer conversation on the policy operations and IT infrastructure around medically frail. We are working with states on this right now, and it is not an easy implementation to work on alone. With that, I'll hand it over to Laura.
Thank you. So also, it's important to recognize that community engagement requirements cannot be implemented with the Medicaid agency alone, that this is really a large number of entities that are going to be involved either directly or indirectly. So this slide highlights some of the key partners that are likely going to need to be involved with community engagement. You've got Department of Labor that may support employment verification, workforce programs, and referrals. SNAP and TANF agencies can be important data sharing partners and eligibility coordination partners. You have Medicaid managed care organizations that could support beneficiary outreach. In some cases, that may be required. Navigation assistance would be critical, and identification of potentially exempt beneficiaries. They are, of course, prohibited from making any specific determinations for those folks, but could play a major role in just helping with facilitating compliance or exemption. Providers also can help with clinical documentation, just like Chris had mentioned as well, and exemption support. Educational institutions, because that is one of the qualifying activities, can be a great referral partner and help with enrollment verification for folks. And then community-based organizations can support volunteer opportunities, provide outreach and navigation, and employers are going to be probably an under-recognized but very critical part of this as well, just to understand kind of what's going on, maybe why they're getting some of these job applications that they're getting, and in the role that they may play in helping people maintain compliance with the community engagement requirement. And some states are already engaging these partners through work groups, town halls, provider communications, and other outreach channels. So that early coordination is definitely important because the implementation responsibilities are going to be distributed across the broader Medicaid ecosystem. Next slide, please. So also beneficiary outreach strategies. Communication is going to be absolutely critical to reducing unnecessary coverage loss. States need to develop and execute a communication strategy, and that is likely going to be drawing on some of the lessons that they learned from the Medicaid unwinding. Some of those lessons do include the importance of repeated, clear, multilingual, multi-channel outreach. The unwinding also showed the value of things like text messaging, call center support, managed care outreach and engagement, and the engagement of trusted community partners. So the challenge here is not just telling beneficiaries that the new requirement exists, but it's helping people actually fully understand whether it applies to them, what actions they need to take, and how to avoid losing coverage unnecessarily. Um, States have announced that some of these strategies are already being implemented to start preparing beneficiaries for the community engagement changes. Direct beneficiary outreach can include things like notices, those are required, but kind of what those notices look like, how often they're coming out, can potentially be enhanced. They're also encouraging states to really coordinate with their managed care organizations if there's managed care in the state to coordinate notices and try to reduce confusion and enhance the experience and the education that's going out. Policy letters, emails, and texts have been increasingly important in getting beneficiaries connected and understanding what the requirements would be. Public education may be necessary and is already being implemented in the form of informational videos. So not just having things in writing, but having like YouTube videos available to help explain the changes. Social media, paid media campaigns, and news releases have all been going out already and will likely continue to go out over the remainder of this year for sure. And community-based engagement may also include some town halls, public events, different efforts to try to get the community and all of those entities that we just talked about in the last slide engaged in this process and understanding where their positions might be in terms of helping people understand what's going on and how they need to respond. Flyers, posters, local signage, so helping people kind of on the ground as well. And then leveraging, again, those Medicaid unwinding lessons. Next slide, please. So health plans, providers, community organizations, and other partners can all play and will hopefully play a major role in helping beneficiaries understand and comply with the requirements. We've been very effective in reducing some of um, the concerns around shame associated with these kinds of public programs by changing the names of them, kind of disconnecting Medicaid as a concept from the health coverage that people have received. And in many ways, that has helped broaden and open the doors for people to access coverage more readily. But in this case, it is going to be a challenge to overcome, just as people maybe associate their health coverage with the health plan that they have, something that was already a challenge with the unwinding and helping them kind of understand, no, you do have Medicaid coverage. This is impacting you, and it's not specific to your plan. But even within that, helping people understand that they are, in fact, an expansion population and not one of the other populations, when a lot of the time those programs are grouped under different specialized names. So helping them understand whether they're in the applicable population, whether they qualify for an exemption, um, whether they um, need to meet the deadlines, what those deadlines are, including renewals or compliance reviews. Currently, they are typically every 12 months. So this idea of having to go through the redetermination process every 6 months is going to be new. And then stakeholders can also help beneficiaries document and report compliance by explaining which activities count, what documentation will be accepted, where that documentation can be obtained, can all be helpful in getting folks through the right door and making sure that they're providing the kind of information that can actually be considered verified for compliance. And then they can also help beneficiaries request exemptions when appropriate. Again, there is a limitation around the level of engagement or amount that entities can do on behalf of that particular beneficiary. But certainly to the extent they can really help point them in the right direction, I think could be critically helpful to retaining their coverage. And next slide, please. And so also all of these changes are going to have enormous systems and data implications. So states are going to need to update their eligibility workflow configuration, application logic, eligibility rules, and they're going to need to enhance their data and automation capabilities, data matching, verification processes, automated compliance determinations where appropriate, and integration of new data sources. Member communications are going to also need to be supported through these systems updates, notice generation and tracking. And then finally, reporting and oversight are going to be absolutely essential. States are still going to need to monitor compliance with federal requirements, generate not only the same performance metrics that they generate now, but add on some, and support with audits and report CMS required outcomes. So there are a broad range of issues that states are going to have to handle on the systems side. So I will go ahead and hand it off to Rob.
Great, thanks, Laura. So we wanted to spotlight, now that we've talked a little bit about some of the policy requirements and kind of what different stakeholders need to be thinking about, we wanted to just spotlight kind of what does successful implementation look like, and it kind of depends on which hat you're wearing. So we have three successive slides, and they'll be available in the slide deck that goes out after today's call. But we wanted to spotlight kind of, what should state Medicaid agencies be thinking about? We've talked a little bit about it kind of on today's call, but this slide really sums a lot of that up. So, there's considerations around systems and eligibility systems to calculate compliance, et cetera. Really wanting to automate as much of the process as possible. Second is around staffing and training, thinking about partnerships, because obviously states can't do this alone. Again, we've talked a lot about communication and lessons from the Medicaid unwinding. So that is another component of what state agencies should be thinking about. And then finally, data and reporting. Obviously, compliance will be a big factor as part of this work. Next slide. From a plan perspective, we want to just highlight that plans are really going to be playing a critical supporting role, helping to identify members who may be affected, helping with outreach and navigation strategies to help those members, thinking about how to leverage care management programs to help identify and support members. And then again, plans will also need to be thinking about their systems in terms of tracking outreach, exemption status, et cetera. So a lot here for plans to be thinking about. And then next slide. From the provider side, we wanted to spotlight that they are also a piece of this puzzle. A lot of frontline staff, including kind of financial counselors, social workers, patient navigators, they're going to need additional training on kind of what these requirements are, what the exemptions are, help identify patients who may qualify, for example, for medical frailty and hardship exemptions. So while providers don't determine eligibility, they will certainly play a significant role. And next slide. So as we close out this section, we wanted to just emphasize how compressed the timeline really is. We are still waiting some CMS guidance. We also wanted to mention, as many of you are aware, there is litigation that states have filed, which will be working its way through the court system. So that introduces a level of uncertainty. That said, planning is underway. Policy development, system mods, operational planning, beneficiary notifications need to go out before implementation, and then ultimately the January 1st, 2027 date is the implementation deadline. So a lot is happening, and a lot will continue to happen. And again, these slides will be available after today's call. So with that, I want to transition our discussion over to the next piece of today's conversation around Section 1115 waiver guidance. So I'll pass it off to Patrick.
Thank you, Rob, so much. So as Rob noted, I'm going to speak to the new changes to budget neutrality as a result of recently issued CMS sub-regulatory guidance. And I would note here at the outset that while this is a separate topic from community engagement, which we just discussed, it does reflect the same broader trend toward a more rigorous approach to federal oversight, and in addition to more detailed expectations for Medicaid program design, financing, and approval. So to go into a bit of detail about this new sub-regulatory guidance and then its implications. By way of background, although I'm sure many participants on the call are already aware, Medicaid Section 1115 demonstrations are authorized under Section 1115A of the Social Security Act, and they allow the Secretary of Health and Human Services to approve experimental, pilot, or demonstration projects, often referred to colloquially as 1115 waivers, if the Secretary finds that they are likely to promote the objectives of the Medicaid program. The new State Medicaid Director Letter, which is a form of sub-regulatory guidance, and it's State Medicaid Director Letter 26003, it outlines a new framework for the concept of budget neutrality. And this new framework has the potential to fundamentally change how states will design, finance, evaluate, and renew their Section 1115 demonstrations. I should note here that it has been CMS policy, longstanding policy, to require demonstrations to be budget neutral or satisfy budget neutrality, which has been understood historically to mean that federal Medicaid costs cannot be in excess of what they would have been without the demonstration in place that the state is proposing. The OBBBA added budget neutrality as a statutory requirement for the first time. And this sub-regulatory guidance provides states with early notice regarding the changes to budget neutrality that CMS intends to put into place through future rulemaking, meaning they are going to issue regulations that have the force of law to comply with this new statutory provision that is now in place. So to go through briefly here on this slide, the various key changes in the key areas that the letter that was issued outlined. And again, this will take effect on January 1st, 2027, and the letter was issued last month on June 11th, 2026. So the first category of change that you see noted here is on the budget neutrality determination. And so under the proposed framework in the sub-regulatory guidance, now the CMS Office of the Chief Actuary must certify budget neutrality of each demonstration prior to approval and must engage in an actuarial analysis of the projected financial impacts of the individual demonstration proposed on a by activity basis and looking at it holistically. So in the past, this contrasts to what the past practice was, where it was actuarial certification was not required, and it was not an actuarially driven process. In the future, CMS is putting into place a process where that will be the requirement. In the second category, the budget neutrality expenditure limit, the new process outlines that demonstrations cannot be approved if they are expected to result in an increase in federal Medicaid expenditures. And so the historic concept that was in place of an expenditure limit or a budget neutrality cap is no longer applicable. It's simply that the actuary must prospectively certify that the demonstration will be budget neutral to the federal government. There is based on the projections and the data provided through that process. In the next category, expenditures in absence of the project, the guidance introduces a new concept known as Medicaid authorizable populations and services, or MAPS. And these are defined as populations and services that the state could otherwise have covered even if the 1115 demonstration were not in place. The important change here from the past is typically the concept that is most equivalent to this was known as hypothetical expenditures, and they would have no budget neutrality implications. In order to have no budget neutrality implications, now you have to have both, you have to pair both a population and a service. It can't be one or the other. So the change is really from an or to an and. So it's a more strict criteria. And then moving on to budget neutrality monitoring, CMS proposes that it will employ new special terms and conditions related to how it will monitor states' compliance with these requirements, and it will impose corrective action if expenditures substantially deviate from what's originally projected. Although there is an additional detail fully fleshed out in the guidance that we anticipate would be fleshed out in future rulemaking by CMS. Finally, there's a change to how demonstration savings and rollover can occur into subsequent renewal periods of the 1115 waiver. And so what the guidance proposes is that current demonstration period savings plus a limited rollover of the previous demonstration period can be used to offset the current demonstration period costs. How this is different, again, from the past is that it was typically permissible for current demonstration savings plus a rollover of 10 years of legacy savings to be used to offset costs. That's not going to be permissible any longer. It's going to only rely on the immediately prior 5-year demonstration period. So again, a more restrictive approach to how savings can be carried over and rolled over. If we could move to the next slide, please. So just really, really briefly before we turn to a slightly deeper dive on the actuarial implications here. The ultimate implications here, the bottom line I want you to come away with, is that states are going to need to build more time into waiver strategy, scenario planning, financial modeling, and stakeholder engagement as a part of their 1115 processes. And there's a number of very specific implications that states will have to consider and that we anticipate will have downstream impacts. So just to quickly review them here. The first is more in-depth analytical capacity. Because this is now an actuarial process, states are going to have more intensive internal analytic capabilities or be able to go out and obtain those. I would note that CMS does not require in the guidance that states themselves use actuarial analysis. However, it's very difficult to see how it would be practical for a state to be able to succeed through this process without procuring actuarial support for the 1115 waiver submission. Other important implications that are outlined here that you see on this slide, how states design their demonstration based on all these new requirements may change because they have a more limited ability to include innovative proposals given the changes to budget neutrality and what will count or not count in terms of having to satisfy budget neutrality savings estimates. Again, similar implication here you see related to financing, which is that because savings are more difficult to accumulate as well as carry forward, States that have used those savings historically to offset costs for new innovative and more expansive policies in future 1115 waivers will find that much more difficult to accomplish under this framework. And so we'll need to consider how they design waivers under this new framework, taking this into account. Similarly, the implication for that as well is that states may need to look to other authorities outside of 1115, and CMS, in fact, in the guidance encourages states to do so, to really look hard at if 1115 waiver authority is strictly necessary to pursue the state's policy objectives, and try to avail itself of other authorities if possible. And the last two points here really go to the opening point I made for this slide, which is that what states can do right now, along with their stakeholder partners, is to really engage in scenario planning based on the policy goals they want to achieve, either through modifications of their existing waivers when they come up for renewal, or in future waiver proposals that they were actively considering. So looking at different scenarios and different avenues for accomplishing those same policy goals, and looking at which ones they truly want to pursue through an 1115 waiver, and which they want to pursue through other authorities or other policy measures. And that an important implication of all of that is that this is going to take a much longer time period and more intense, resource intensive process for states to be able to not only do the scenario planning, but actually go through the 1115 waiver application process. So it's something states are going to have to plan for and make sure that they're well resourced to be able to succeed in. So with that, I will turn it over to my colleague Elric to talk a little bit more about the actuarial implications of this brand new guidance. Elric?
Thanks, Patrick. And I'm going to build a bit on some of the points that Patrick brought up in the previous slides, but we'll offer an actuarial perspective, again, based on the current information available. The first point here, which Patrick noted, moving from that retrospective review process to a prospective approval. The current 1115 waiver approach includes budget neutrality monitoring throughout the waiver demonstration period using actual experience, which allows both the states and CMS to assess performance retrospectively. The with waiver and without waiver calculations are important, but the retrospective nature of the process means there's an opportunity to reconcile assumptions against emerging experience. Going forward, approval now depends on demonstrating before implementation that the waiver will not result in increased federal expenditures. This means the projection piece of the budget neutrality calculation becomes more consequential. Approval of the demonstration will hinge on the budget neutrality calculation, which leads to our second point here, more robust support for the budget neutrality calculation. I think a key call out in the June 11th state Medicaid director letter is the note that the information that states provide under the current demonstration application and the current budget neutrality test are not sufficient for the chief actuary to certify budget neutrality. Documentation focuses primarily on the final calculation and key assumptions. Under this new approach, CMS expects substantially more detailed support for all assumptions, methodologies, and data sources. This means the projections going into the calculation need to be more transparent, reproducible, and well documented. Essentially, the standard of evidence is increasing. States and their actuaries are going to spend a lot more time validating assumptions, documenting methodologies, and ensuring analyses can withstand independent review. Adding to this elevated level of rigor is our third point here, the separate treatment of the MAPs and the 1115 activities. Currently, all expenditures, 1115 activities, and then those that could have been covered under another authority, usually meeting the definition of hypothetical expenditures, can be evaluated together within a broader budget neutrality framework. Now these activities must be separated, meaning savings in one area can no longer cover expenditures in another area. And additionally, each 1115 activity must have its own set of documented expenditures and assumptions. Finally, here, all of this comes with greater CMS involvement during the approval process. As I noted before, the current process generally has CMS reviewing the budget neutrality throughout the demonstration period. Under this new approach, the chief actuary for CMS must approve the budget neutrality calculation prior to the demonstration period. Expect a more iterative engagement between the state and their actuary and CMS throughout the approval process. I don't think it's unreasonable to assume this new process may look similar to the Medicaid managed care rate development and approval process. In that process, states submit robust documentation to CMS prior to the rating period, and then there's typically a few rounds of Q&As before rates are approved. This seems to be where CMS is headed now with the 1115 waiver process. And on our next slide here, we provide an overview just for illustrative purposes of what that new process might look like. It'll start with the demonstration design, with the state developing their proposal and performing a preliminary budget neutrality calculation or proposed methodology for that calculation. This would be followed up by CMS engagement, offering an opportunity for the state and their actuary to solicit early feedback from CMS. Then a formal submission and technical review would occur, with the state submitting their waiver application, including detailed documentation and financial analyses supporting the budget neutrality calculation. A CMS review would begin, likely resulting in requests for additional information or adjustments to analyses, and the state following up with responses and applicable adjustments as needed. And finally, the CMS chief actuary would certify budget neutrality, and CMS would provide final waiver approval. All of this occurring prior to the start of the demonstration period. Taken together, these changes don't necessarily alter the actuarial methods currently being used for budget neutrality calculations. Rather, they raise the expectations around transparency, rigor, and prospective credibility. And again, we'll note, as with any significant policy change, our observations are based on the information currently available. We anticipate additional CMS guidance that may further clarify or refine these requirements over time. And with that, I will hand it over to our moderator, Jennifer, to start the Q&As.
Thank you, everyone. We have a lot of great questions and we won't have a lot of time, so look for some follow-ups. I think thematically, certainly lots of questions about state readiness and funding and availability of resources to comply with these things, transitional support for people who lose eligibility. Great question. Actually, Patrick, if you might have an answer, whether the ACA will have a kind of ongoing open enrollment for anybody who loses eligibility. I think the answer is no, but it may depend on the state. So if you have an answer for that, that would be a great live.
No, Jen, absolutely. I would answer that the same way. I think there is, if the question is there any kind of blanket, open enrollment that will be in place as or as a special enrollment opportunity? I don't believe that that's the case. Correct.
Yeah. Okay. All right. Good. Lots of questions on, communication. I think we talked a lot about MCOs and the opportunities they have to communicate with members. There's a lot of questions around clarifying around frailty. So maybe I'll ask the question, and whoever wants to jump in, is medical frailty an exemption or an exclusion? And the fact that, frailty and sort of hardship may be complicated and maybe two sides of the same coin for some folks. So if anybody wants to jump in maybe and just take that for a moment in terms of clarifying how we're thinking about frailty in that regard.
Yeah, we often interchange the words and trying to keep it simple, but as we get more and more into the IFR and defining our policy and operations, we are going to get a little bit more specific over time that medical frailty is a specified excluded status under the IFR. And states assess whether an individual meets a specified exclusion during the application or renewal. If an individual meets the exclusion and is therefore a specified excluded individual, states do not check compliance with community engagement requirements. There's other conditions, other exemptions that you check in the month prior to application. So that's why states are slowly getting their language down in terminology of what they want to use that is checked in the month prior to application versus what is checked in the month of application.
Okay, that's great. I'm sure there'll be follow-ups on that. So in terms of the functional requirements on frailty, these sort of new requirements, is there a standard? I know there's sort of ADLs and things that, in a standard way assess people's functional abilities. Is there a standard measurement that might be applicable here in terms of this new functional requirement on medically frail people?
That has not been determined yet. States are seeking that standard, and they're optimistic they will get direction from CMS, who has been telling us that information is coming soon. And they've been telling states that for a month now after the IFR has been released. So states are working together, they're working with consultants, and they're really waiting for firm direction from CMS on what standards are allowable. Vendors are working on these components to set a standard and IT components, but at this time, none of that has been certified or sanctioned by CMS that yes, you can use this IT standard or this group or list, and we can go on from there to determine if someone's medically frail.
So in terms of screening and so forth, MCOs and providers would be looking to states first to determine what to screen for, and then they can implement that screening?
Yeah, states will have to develop screening tools that can then be used by their MCOs. Their MCOs could then use those screening tools to help inform members that they may meet the medically frail information, or they can communicate that back to the states. However, MCOs cannot actually be the vendor who is performing the screenings on behalf of the states.
Okay. Speak to maybe, Patrick, this might be for you and Laura in terms of your experience with states. There's kind of a question about the burden on states. Obviously, we've put forth, clarified the timelines and the urgency with which states need to act here. Obviously, budget environments unknown, additional resources, competencies, et cetera. How are you advising states in terms of, their how to manage all of this, really?
Sure. Laura, did you want to go first, or I can jump in? Yeah, I'm not big. Sure. So, I mean, fundamentally, Jen, and I know I saw a version of that question. Someone was concerned. Certainly, all of that, this additional administrative burden, right, and the resource-intensive needs that states need, not only for the CE requirements, but I think there's also implications as we discussed for the 1115 waiver resource intensity, and all of states dealing with that at a time when we're expected for state finances to be measurably more constrained, right, than they have been in recent years when there's been more federal dollars available prior to the most recent federal action. So I think states are going to need to look to a more austere time, which again, many folks in states, certainly there's long-term state officials who have had that experience, but there are many state officials who don't have that experience because they've only experienced that. And so it is going to be a new mindset where I think the states are going to have to look for either one of two options fundamentally. It's going to be in partnering with their legislatures to look at, given the federal requirements, what possibilities are there for enhancing resources and funding at the agency level. But obviously that's going to be a competing set of priorities against a whole range of state priorities states are trying to navigate from a budgetary perspective. And then the other piece I think is going to be really important is for states to think incredibly creatively about what are the savings initiatives that they can find where they can either redirect or create budget room for themselves to be able to actually resource some of these important compliance activities. But I think if the underlying kind of thrust of these questions is there likely to be more federal support for these to comply with these requirements? I think all the signals we're seeing is that that's unlikely to be the case in most cases.
I would agree with all of that. And some of the things we have been seeing, some states have been setting aside some additional money for hiring additional staff. And I feel like that has probably been the key direction that we've been seeing states going in terms of trying to enhance their capacity for this. It's definitely been a mix in terms of the number of states that have been doing that and just how many extra folks they've been hiring on. But I think that's one of the key strategies that they've been actively working on. And then I think the other piece, just in terms of trying to manage it, is trying to figure out where they can, I don't want to say cut corners, but just like simplify things administratively as much as possible so that it's not taking as much staff time, it's not taking as much follow-up, so that it just reduces the administrative burden for both the member and the staff.
So the timing of further clarification on some of this, are we waiting on a sort of a final set of guidance, or are we just sort of, do we know when we'll know more specificity around some of these questions? The unknown.
So we are anticipating additional sub-regulatory guidance from CMS on this. They know that there are a lot of outstanding questions, but I think kind of like Chris had said earlier, the best I've heard is soon, and not any sort of specific date.
Mm. Not not unimportant that obviously with all these changes happening at the end of the year and the potential for personnel changes as a result of elections, a lot of governors' offices on the ballot this year, whether a change party or not, still could change personnel. So adds to the complication. We will continue this conversation next month with program integrity, which of course is one additional piece of this puzzle and very relevant to the overall change that's required of states right now. So appreciate all of the insights. We did not get to all the questions. We will definitely send some follow-up answers to those questions along with the slides and the recording. Really appreciate everybody's time today and the talents and insights of this fantastic team. So thank you all. And we will see you next month. Thanks so much.